Firstly, warm welcome to everybody for this afternoon's session. And we have very highly qualified and esteemed faculty today. Our presenters, first presenter, I'll just give you a brief introduction about her. Is Janet Nguamau. She is the lead therapist and lead lymphedema physiotherapist at Kenyatta National Hospital. She trained as a physiotherapist at Amref International University, and then did her lymphedema training amongst other places in Kenya under Susie Davy. And at the moment, she's the lead for this project. She is creating awareness. She's an advocate about that. She's also affiliated with the International Lymphedema Framework. She is going to speak to us about
Apologies for the interruption. Dr. Mustafa,
can you hear
apologies
me?
for the interruption.
Yeah.
We can't hear you clearly. Your sound is a bit muffled.
Give me a second.
So can you check on that?
Yeah.
We're hearing you, but very faint.
Can you hear me better? I think it's where I am. Can you hear me better now? Hello?
Yes, it's better.
Come again?
Hi, can you hear?
Yes, it's better now.
Okay. Yeah, sorry. So I was just introducing our two speakers today. We have a very esteemed and highly qualified faculty team today. We have Janet Mungomwao, who is our lead lymphedema physiotherapist at Kenyatta National Hospital. She is also, I would say, the champion in Kenya for lymphedema. She did her initial training at Amref International University, and she's a known certified lymphedema therapist. She's also an advocate, a very strong advocate, I must say, for lymphedema in the country. She's affiliated with the International Lymphedema Framework. She is going to speaking to us about management of lymphedema today. The second speaker is Susie Davy, and he is going to be speaking to us about decongestive therapy in lymphedema, which is again a cornerstone of lymphedema care. And just a bit of background about Susie. She's currently based in South Africa. She has founded the Lymph Africa Limited Society and Company. She has taught on many courses. She is actually the lead for the first official lymphedema management certification course, which was done in Nairobi, and there were about 14 physiotherapists on that course. She also served as the president of the Lymphedema Association of South Africa from 2016 to 2018. So as you can see, we have a very good, strong, very well qualified and well-versed faculty today. So please, to the audience, make sure you take full advantage and keep your questions ready for them. So we'll start by Janet. The floor is yours. Thank you.
Thank you very much, Dr. Mustafa. I hope I'm audible. Someone confirm that, please.
We can hear you. Perfect.
Okay. Yeah, thank you, Susie. So I'm gonna need Nelson to drop the presenter screen. I think they can do stop sharing. Okay, yeah, I think we're good. You able to see the screen? Yes. Okay. So today we're going to be doing a presentation on the following topics: staging of lymphedema, diagnosis, lymphedema management, the need for multidisciplinary approach, and role of physiotherapists in lymphedema management. So we're going to start with the staging. And this is where we have, so lymphedema is staged in 4 stages. We have the stage 0, stage 1, stage 2, and stage 3. So stage 0 is actually the latency stage or the subclinical stage. We do not have any visible swelling in this area. However, the lymphatic system is impaired and we have impaired lymph transport. Patients at this stage will mostly come to you and tell you that they have feeling heavy, they have problems lifting their limbs, they just feel tired with one limb. So you're going to, that's how you're probably going to be picking this stage of lymphedema. There's no any visible swelling, there's no difference in lymph circumference measurements. There's also no pitting, there's just the feeling of heaviness among patients in that stage. And then we have a stage 1, which is actually reversible edema. It reduces with elevation, with the right prescription of the compression garments, with exercises, modified exercises for lymphedema, especially ankle pumps with elevation and anti-gravity exercises. We also have stage 2, which is spontaneously irreversible. At this stage, we have fibrosis, which is already begun. We have minimal pitting, and the stomach sign is going to test positive. We are going to be talking about the stomach sign going forward. So fibrosis is basically hardening of the skin tissue. We talked this in the last session when we were talking about the pathophysiology of this condition. And we are going to be also doing the classifications of pitting as we move forward so that you know what minimal pitting is. Then we also have stage 3, which is lymphostatic elephantiasis. We have a severe swelling at this point. We have skin changes, papillomas. I want to, and repeated infections. Sorry for that, guys. We have repeated infections at this stage. You can see that limb, which is actually attached there in the stage 3, how it looks like. Each and every patient presents differently at this stage of lymphedema, and this is where now we need a multidisciplinary team. These patients, they need a lot of mental health counseling, they need nutrition they need nursing for the wound care, we need the vascular doctors, we need the surgeons, the plastic surgery, the physiotherapist, which is key to the management of this condition, and also a certified lymphedema therapist. So this is the staging as per the International Society of Lymphology. And you can see clearly at stage 0, we do not have any, I did not have any image for stage 0. It's actually just me and you probably. And then we have stage 1 where you can actually differentiate the swelling. And we have stage 2, you can see how it looks like. And then stage 3. When you're going into books, some books might say stage 1 to 4, but this is the classification as the per the ISL. So make sure you follow this classification. So we're going to do diagnosis of lymphedema. The clinical, of course, we have the clinical assessment, and then here we're going to be having the key components for evaluating suspected edema. So the first thing you need to do is to take the medical history. Start with the onset and progression. When did the swelling begin? What triggered it? Where? When does it get worse? Does it ease? Does it fluctuate? When you elevate, does it go down? When you do activity, does it become less or does it become more? Make sure you get this information from the patient or the caregiver. Then also the risk factors, if they have had cancer, surgery, radiation, chemotherapy, treatments, any lymph node dissection, any infection, cellulitis, or any other form of infections. If they have had trauma before, any diagnosis with venous disease, also diabetic, and very many other factors. Just check around all the risk factors that can be associated, maybe also risks of clots. DVT, do not forget that. And now get to the symptom and impact. Do they feel heavy? Do they feel tightness? Tightness might even also come when they're putting on their jewelry. And sometimes it's actually because of the overstretched skin tissue. That is why they feel like this is actually tighter than the other. Do they have pain? Are there any skin changes? Hemosiderin staining or maybe hyperkeratinized skin, change in skin color, things like those, recurrent infections again, and any functional limitations. Is this causing, are you not able to do your daily activities like you're doing? Are you able to participate in the community, at workplace, and all that? Then we also have the red flags to rule out. Acute unilateral swelling. This is something that we're going to be having elaborated more by Dr. Cedric in his presentation on that. Then we have dyspnea and chest pains. This is very common with breast CA patients when they start having fluid accumulated in the chest wall, pleural cavity. They are going to come to you with chest pains, sometimes coughing, difficulties in breathing. That is a very, very big red flag. That patient you don't let go home. You follow up with the other doctors, the chest physician, or any other doctor who is involved within the management of that patient. We have fever, any increase in temperatures, the area of edema, or also reduction in temperatures. Then we have also rapidly worsening pain. And then inspection and palpation, which you have to do. So distribution and symmetry. So that area which affected, the limb, the hand, the foot, where is it involved? Does it go laterally? Does it go medially? Is it same? Make sure when you're assessing here, you check both the limbs. If it's the trunk, check both sides. Check unilaterally. Do not just look at this. You need to assess both and see if there is any difference, if it's the trunk, if it's the genital area, people with hydrocele. Check if the swelling is on both sides and what is the difference between one leg to the other, the discrepancy. Do that in measurements. Also, we have skin and tissue changes. We have pitting versus non-pitting edema. Again, we're going to talk about that. We have purely orange. This is basically a skin which looks like an orange. We all know how an orange looks. This is actually a French word. So when there's a lot of accumulation of fluid in the skin, we have, the skin pores can show and looking like there's a lot of fluid accumulating in that particular area of swelling. Something that looks like that. You have to identify those things. Fibrosis, the hardening of the skin tissue, again, we talked about that. Hyperkeratosis, hardened skin, skin changes, scaly skin, and things like those. Also, do not forget to look at things like scars around that area, especially if it was because of the surgery, especially the lymph node dissection, post-breast modified mastectomy. We have something we call axillary webbing, which actually forms in the axillary area. So sometimes you check where the scar is coming from and if there are any changes also which might have been compromised because of the scar. Do palpation of the tissue texture, tenderness, temperature, and presence of pitting, and grade the edema also. And then we have differential clues like varicositis, skin hyperpigmentation, which is venous, and generalized edema, which is systemic, again. So the grading of edema now, very important. Edema is not detectable clinically until interstitial volume reaches 30% above normal volume. Earlier when to explain the accumulation of fluid, it was like 3% of it does not get back to the circulatory system. That is what drains back to the lymphatic system. If the lymphatic system is not working properly and that fluid keeps on accumulating, then we are going to have this 30% here. Also, when you're checking for edema, you use your finger, press on the skin. Do not just press and lift. Press your skin for at least 5 to 10 seconds and lift. We grade edema depending on how the dentation, the refill after the dentation has been formed. So you press your hand on the skin and then you count to 5 to 10 seconds and then lift up and then see how long is it going to have the skin refill up. So we have a 1+, which is barely detectable edema. 2+, which is slightly indentation and visible and remains when the skin is depressed. Now, the third one is deeper fingerprint that returns to normal in 5 to 30 seconds. 5 to 30 seconds. The fourth one is extremity, is 1.5 to 2 times normal size. So like the elephantiasis leg, the you're not going even to be, when most of the time, also understand when there's a lot of fibrosis, you're not going to get pitting edema. It's not going to be pitting. The skin is already had the edema, and now it has even hardened more. So you do not confuse about the two. You do not go press and there's no edema, and then you're like, actually, my hand is slipping on the leg. That is also possible. So we have a stammer sign. Now, how do we perform this? We attempt to pinch or lift the skin fold at the base of the second toe or finger. So this is my second finger right here. So this is where we pinch. Okay, this is my first finger. So this is my second finger. So if you can't pinch this, try that on yourself right now. I think you have edema. If you can't pinch that skin right now, you can just try that or remove your shoe. Pinch on top of the second toe. See, if it is not coming up, I think you have edema and you need to be managed. So it is a positive sign when you're unable to lift the skin fold, and it suggests lymphedema, especially in later stages. So that is probably stage 2 and 3, and also sometimes at stage 1, it is positive. This sign is negative when skin can be lifted. It does not exclude early or mild lymphedema. Remember, at stage 0, we said that we do not have any visible swelling. You cannot look at like this and say there's swelling, there's edema, yes. So that means still at stage 0 of edema, the stammer sign can test negative, so that we do not get things wrong. Remember how to differentiate between diagnosis at stage 0 and the 3 other stages. So use alongside other findings, combined with the history, the exam, and the measurements for staging. So do not only depend on the stammer sign. So this is how we do the base of the second toe. I don't know if my images are actually all right. So if you're not able to lift this skin, just type down here that you have edema, and we are going to have a follow-up on you. And we have circumferential measurements. We have a standardized technique. We measure at consistent landmark at every 4 to 10 centimeters. Okay, mostly when you do the course, you're going to be doing after every 4 centimeters. It's easy so that you can get consistency. If you're measuring between the left and the right arm, you measure every 4 centimeters, you take measurement. That way you're going to have your limbs at standard, and you can even do a good comparison. You do not stretch the tape. So the tapes that we use for measuring the limb circumference, they should not be those that stretch. They should be non-stretchable. Compare sites and track over time. Calculate limb volume and estimate or percent difference. So also that guides you in treatment, especially someone with unilateral limb swelling or unilateral area swelling. You're going to be able to do the measurement, and you know your target is actually the limb that is not affected. So that also helps you track your treatment. Document your conditions. Same time of day, same posture, and not compression used before measuring. Most of the time, if your patient has gone home and came in with a compression and you did exercises, do the measurement before you do compression. Again, don't do compression, then remove, then take measurements, and then that is not going to be right documentation, and that's not anyway right reading. So the clinical interpretation is increased girth or volume supports progression, guides gametes, and therapy fits. So we have the diagnostic images, we have ultrasound, we have MRI, and we have lymphoscintigraphy. So ultrasound, we rule out the DVT, venous insufficiencies, access to soft tissue edema, and fluid versus fat. Now, this is very important. I think this is actually just basic and simple as it is. When someone comes to you with swelling, and especially a walk-in patient, and they have, those things that we found there, the increased temperatures, fevers, history of a lot of things, I think you should send them to the vascular doctors They will go assess, they'll send the patient for ultrasound, and they will send back the patient with results. And you do not have a vascular doctor nearby, I think the ultrasound can be still found there because they do not carry the ultrasound machine with themselves everywhere they go. Maybe they do. Yeah, but also make sure you send that patient for ultrasound. You write that test to be done, and then so that we avoid mortality with DVT. We have MRI or lymphoangiogram, which evaluates the tissue composition, fibrosis, and lymphatic anatomy. This is done very much, especially in cases where patients, they have lumps and other conditions that are related to the edema. We have lymphoscintigraphy, which you will be told more about it by Dr. Cedric. Again, it is a functional test of lymphatic transport. It identifies delayed or dam or backflow patterns. This lymphoscintigraphy not only does that, I think also it tells us the area of blockage or the area of compromise within the lymphatic system. And that way, as a therapist or as a physio, you're able to redirect fluid to the other regions which are not compromised. Now choose imaging based on question, exclude acute vascular cause first, use lymphatic imaging for confirmation and also for planning. Now your documentation checklist should be having a record baseline and a follow-up measurement with dates and method used. Note skin integrity issues and infection history, educate on early cellulitis signs, stage severity and functional impact to guide therapy, intensity and referrals, and reassess regularly and escalate to imaging or specialist if presentation is atypical or worsening. Yes, we have cases of atypical lymphedema. I think all the signs that we just told you that do not actually apply. Like I had one patient some time back who had lower limb lymphedema. It was actually one limb, but it was so big, the lymph volume was so big. No pitting, no fibrosis, no changes in skin tissue, just flabby there. So I had to call in now the team so that we discuss about that patient because that was lymphedema, but not a typical case, but an atypical case. So we also check severity of lymphedema based in unilateral lymphedema or lymph swelling. We have mild, where we have less than 3 centimeters difference between limbs, and that means there's less than 20% increase in lymph volume. Well, that is something actually which is observable. Okay, moderate, which is 3 to 5 centimeters differential. Accumulation of 20 to 40% or increase in the lymph volume, and then we have a severe, which is greater than 5 centimeters differential. That means it's greater than 40% in lymph volume. That is a very big lymph. So differential diagnosis, again, primary lymphedema, secondary lymphedema. Lipedema, which is actually accumulation of fat, especially in middle-aged women. It's caused by widespread distribution of subcutaneous fat and fluid, basically maybe because of hormones. Then we have chronic venous insufficiency and reflex sympathetic dystrophy or complex regional pain syndrome. We have the complete decongestive therapy. This is where the history began. Now, Hippocrates in 400 BC described lymph nodes as vessels containing white blood. Thomas Bartholin in 1637 described the lymphatic system as a natural cleansing and drainage system. I think we already talked about this earlier. Then Olaus Rudbeck in 1630 to 1702, he identified lymphatic vessels of the colon and rectum and confirmed their drainage into the cistern chalae. And the first recognition that lymph returns from tissue through lymphatic vessels to the thoracic duct and back into circulation was also found by this Olaus Rudbeck. Then we have Emil Voda and Estrid Voda in 1932, who initiated research on manual lymph drainage, and they recognized that the lymphatic system was poorly understood at that time and developed a light rhythmic hand movement to promote lymphatic drainage. So that's where the MLD started. So The VODA technique of MLD was formally introduced in Paris and France in 1936. Now, in 1974, Gunther Wittlinker worked with Emil Voda to advance and promote recognition of VODA MLD technique. This is a very good team. They founded the Wittlinker Therapy Center of Lymphedema. Now, Michael Foldy in 1980 established the Foldy Clinic and School in Germany, advanced lymphedema therapy by combining manual lymphatic drainage, compression bandaging, skin care, and exercise, forming what is now called the complete decongestive therapy, and that is how we manage lymphedema. In 1988, Steve Norton, a certified lymphedema therapist, co-founded the Close Norton School of Lymphedema Therapy in USA. And in 2015, Robin Jock founded International Lymphedema and Wound Training Institute, integrating lymphedema and wound care education. So that is basically the history of complete decongestive therapy, which is the management of lymphedema. And that is where we are going to have Susie take us from. So I'm going to drop my slide. Oh, yeah, she can do it already.
Hey, thank you, Janet. So let me see. I need to share my screen here. Let's see. Where's my window that we're looking for? I think it's this one. Yes, let's share this one. Oh, no, it's this one. Sorry. Slideshow. Okay, can everybody see it?
Yes, Susie.
Okay, very good, very good. So thank you so much, Janet. That was an excellent introduction, and I'm so proud of everything that you've accomplished in Kenya. I'm going to be presenting on the next aspect, and this complete decongestive therapy. I was originally certified through the Dr. Voda School in 1998. So have been doing this work for a very, very long time, probably before some of you were born. And then in 2012, I moved from America. I was in Miami. I had a multidisciplinary clinic for over 15 years, moved to South Africa in 2012 and recognized there was a need, that there were a handful of therapists doing this work, but a very small pocket. So I went and became a clinical instructor with the International Lymphedema Wound Training Institute, because in my clinic early on, we were using the lymphedema with the wound care. And in the USA, physiotherapists and occupational therapists work together with wound sisters and doctors and are able to do that. But here in South Africa, wound care is done specifically by nurses. So with this work, we realized there was a need for teaching more the complete decongestive therapy and less of the wound care. So what we do here and what we teach about is, minimize this. Oops, let me go back. So the intensive versus the maintenance phase is the key components and the clinical goals of combined decongestive therapy. The intensive phase involves doing manual lymph drainage, which is a very, very light skin movement technique where we're actually moving the surface of the skin. And if you were here last week, we went through the anatomy and physiology and pathophysiology of how the lymphatic system works. And the lymphatic vessels are just beneath the surface of the skin. So when we are treating lymphedema and using manual lymph drainage, to effectively use it to reroute fluid from the tissues back into those initial lymphatic vessels, the movement of the skin has to be very, very light and very slow to be able to reroute it to healthy lymph node areas. And it needs to be performed frequently for it to be effective. So this is why, as lymphedema certified therapists, we teach the patients to do home care and home self-lymph drainage. After you do the lymphatic drainage, again, depending on what stage of lymphedema the patient has been diagnosed, and if there's pitting edema, is there fibrosis, to effectively keep the swelling out of the tissue, you need to use multi-layer compression bandaging, which is we'll be talking about what is involved in that in a future slide. And then skincare is super important. We want to make sure that there are no infections in the skin. The patients are moisturizing their skin appropriately with a very proper pH balanced lotion, and ensuring that there's no cuts or scratches or open areas on the skin. And if there are, then appropriately using the basics of wound care management and principles to ensure that the skin is intact. And then, of course, exercise is one of the most important aspects, as we discussed last week as well. The lymphatic system doesn't have a pump, so the lymph system is dependent on movement of muscles and muscle contraction, as well as diaphragmatic breathing, to move lymph fluid through the body. So exercise is a very important component, and muscle contraction in the intensive phase. The maintenance phase then, and again, the intensive phase can last, depending on how much swelling there is. The best case scenario is if a patient can come intensively 5 days a week, at least for the first 2 weeks. And then the frequency reduces, and they can come maybe 3 times a week, and then twice a week, and then maybe once a week. But in that time, the edema gets smaller and smaller. Yes.
Sorry to interrupt. I think you've not moved your slides. We're still seeing the first page of the slides.
Yes, I'm still talking about the maintenance phase. So I'm just going through this. Let's see.
Yeah.
Oh,
Okay.
very good. Sorry.
Yeah,
okay.
perfect.
Thank you.
Yeah.
So the goal here is to reduce the limb, the volume, and to soften the fibrosis and control inflammation as quickly and as safely as possible. And then this, in the intensive phase, the goal is the education begins immediately. The patients need to understand that, as with every physiotherapy, right, there's an instruction, and then the patient needs to embrace what you're instructing, and they need to do their part at home. So it's a 50-50. And they need to be taught how to care for their skin properly. They need to learn how to do the movement and exercises properly. They need to understand the precautions of what they might be doing at home that's causing them to swell more. And early management, early self-management skills is the cornerstone of the complete decongestive therapy. And then, of course, the high frequency treatment, often, as I mentioned, either daily or several times per week, is very important, especially the larger, the stage 2 or stage 3. It's very important that the patient comes frequently, because you really need to stimulate the lymphatic system intensively in the first few weeks to get the fluid moving out of the tissues into the lymphatic system and then draining out, as well as then keeping the swelling under control with the bandaging. So manual lymph drainage is performed frequently, like I mentioned. The purpose is to stimulate the lymphatic uptake and redirect fluid towards the functioning pathways and lymph nodes. So, for instance, if you have a breast cancer patient who's had radiation or lymph nodes removed on the left side, you would then want to stimulate the lymph nodes that have not been affected on the right side, on the right side, as well as in perhaps the inguinal area, because you're going to want to decongest the swelling from here by stimulating and creating new pathways. So a typical schedule performed by a trained certified therapist in the intensive phase is more frequent and then tapered. And the key principles are gentle, rhythmic strokes, proximal clearing, meaning if this is the distal area, you want to proximally clear and reroute fluid, decongesting first here, decongesting here, and then slowly working on the area that has the edema. So you want to decongest and clear the area first, and you want to avoid pain and redness. And then contraindications and precautions, of course, if a patient has any undiagnosed acute infections, you don't want to do the lymph drainage, or any type of uncontrolled heart failure, or definitely an untreated DVT. You need to screen the patient first, find out what their issue is, why their swelling is occurring, and if there's any questions with regards to infection, uncontrolled heart failure, or untreated DVT, you need to refer them to a doctor first before initiating any manual lymph drainage. So what is MLD? It's basically, it does stimulate the lymphatic vessels, those initial lymphatic vessels. It enhances lymph transport. It reduces swelling and fibrosis very effectively. But again, we must clear the proximal area first, and the use of light pressure and slow rhythmic movements. Again, you're moving the skin, stretching and releasing, following those pathways of the lymphatic drainage flow, and creating new pathways if there is a blockage and lymph nodes have been removed or surgery has been performed. And this is what it looks like. So the techniques are designed to increase movement of lymph and interstitial fluid. We clear proximally and gentle pressure, the stretch to skin only. So often when I'm instructing new therapists to learn this technique initially, especially physios, right? We want to get in deep and work deep, and that's not always the most effective, because when you're working deep, you're stimulating more blood flow to the area and potentially causing more swelling. So with this pressure, the pressure phase promotes movement of the fluid in the desired drainage direction, and the relaxation phase of the treatment technique. So there's a stretching phase and there's a relaxing phase. And the relaxing phase causes a vacuum case by passive distension of the tissue, which leads to refilling of the lymph vessels from the periphery. So this is the encouragement of that fluid in the tissue to go back in through the lymph system to then be drained properly. So as the techniques, one of the techniques that we utilize and you learn in the certification course, or from taking a shorter, just basics of manual lymph drainage course that is available, the techniques are stationary circles. There's a pump technique. So stationary circle is just a stretching and releasing in a stationary manner, of course, working proximally first and then working distally down where the swelling is. There's a pump technique, which is another specific technique, a scoop technique, which is mostly on fleshy areas of the arms, as well as the calves and thighs. There's a windscreen wiper technique, thumb circles if you have small areas over the hand or on the dorsum of the feet, and then a sweeping technique. And sweeping techniques are more part of a more modern way of treating with lymphatic drainage, and a sweeping method of lymphatic drainage. The MLD contraindications in the abdominal MLD, of course, if a patient is pregnant, you certainly do not want to do any MLD on a patient before 12 weeks and avoid abdominal MLD. But there are special compression garments available with more stretchy pressure area for the abdomen. And then a patient with abdominal surgery, it says to wait 6 to 12 weeks, or again, you can start sooner, but just make sure to get the surgeon's clearance that you can initiate manual lymph drainage on the scar area sooner. Of course, if a patient has radiation colitis, pelvic DVT, diverticulitis, Crohn's disease, abdominal aortic aneurysm, or an unexplained abdominal pain if not yet worked up. And then we go on to talking about, so after we do, so the manual lymph drainage in each treatment session, again, we're limited by our medical insurance or medical aids, right? If a patient is only able to come for an hour session, then the manual lymph drainage, perhaps you will only be able to spend about 20 minutes, 30 minutes, up to 45 minutes, because you want to leave time for the multi-layer lymphedema bandaging. So this is applied during the intensive phase. And again, the reasoning behind the multi-layer bandaging is the manual lymph drainage is moving the fluid out of the limb. And now to keep it from refilling back in, you need to apply bandages. So this includes usually a cotton stockinette. Then we apply cotton padding and sometimes foam padding, different types of foam, uneven foam that helps break up tissue swelling, pitting edema, fibrosis. And then on top of this, we also would, if the fingers are swollen, or even if they're not, you would want to bandage the fingers so swelling doesn't go into the fingers or the toes. And then we apply different sizes of short stretch multi-layer bandages. So there's a few different brands on the market, and short stretch bandages are different from more long stretch bandages, which are the typical athletic type bandages. And this helps to keep the swelling under control because the bandages are short stretch, they don't stretch, and they provide a high working pressure and a low resting pressure. So this is why the lymphedema bandaging kits are different from regular types of bandaging, because patients are more comfortable because at rest, there's a low pressure. But when they're up and walking or they're using their muscles, it's a high working pressure because the bandages don't stretch. So with this non-stretch, when the muscle pushes against the bandage, then now the fluid is getting pumped back up through the lymphatic system and not staying in the tissues. And this is all based on the law of Laplace, again, needing to use different with bandages. Smaller bandages at the bottom of the limb, you start with a 6 centimeter usually, then go onto an 8 centimeter, 10 centimeter. And if you're bandaging up the leg, you even can add a 12 centimeter width bandage. And this reduces the limb volume very effectively. So here's a picture of Janet utilizing the multi-layer bandaging system. She already has the stockinette on, the toe bandages, the foam padding, and now she's adding a 6 centimeter short stretch bandage. So the purpose is to maintain post-MLD reduction, improve tissue pressure gradient, and prevent reaccumulation. And again, like I mentioned, the technique is short stretch bandages with padding layered for graded compression. Again, we want to have more pressure distally and less as we go up because we want the fluid to be pumped up back through the lymph system. Just as when you wear a properly fitted...
Apologies for the interruption once again, Susie. This is Nelson from KNH Research. We can't see your slides moving. Were you in presentation mode? Yeah.
There, tab instead. Are you see it now? Were you still on the same slide? Oh my goodness,
Yes,
I'm so sorry.
Yeah, no worries, no worries.
So these were you didn't see this picture.
Yeah, we didn't see most of your presentation, yes.
Oh my goodness, I wish someone told me. I apologize. So here, I'll go back. So this is the slide. This is the one where it shows the different techniques. This is the contraindications. And again, it talked about the applying in the intensive phase, the multi-layer bandaging. And here's Janet applying the different bandages with the different layers. Again, the cotton stockinette you can see at the toes, the toe bandaging with the foam, and then Janet applying the 6 centimeter short stretch brown bandage. And again, you can see on the right sided picture how there's different techniques of applying bandages. There's just circular way of applying the bandages up. And then there's a figure of 8. The figure of 8, of course, uses more bandages, but it's a more containing type of bandaging system. And so the technique is to create a graded from distal to proximal. And the wear schedule in the intensive phase is you do need to wear the bandages to get the most effectiveness out of the therapy, to wear 23 hours a day. So this is difficult for patients to maintain, but the proof is in the results. And during the intensive phase, the patient comes in, the therapist then removes all of the bandages, washes the skin and cleans the skin, hopefully with warm soapy water, and dries it properly, does another series of either a half an hour, 45 minutes of manual lymph drainage. All the bandages need to be re-rolled, or you have 2 sets of bandages, and then the bandages need to be applied. And then, of course, safety checks while the patient is being bandaged. We check for numbness or color change in the skin or the toes or the fingers, increasing pain or cold digits. And of course, if there aren't any concerns, you remove and reassess and then reapply the bandages. So here is another picture of the multi-layer compression and the different types of bandaging products that are supplied to a lymphedema patient when they're undergoing complete decongestive therapy. So the principles are the short stretch bandaging for lymphedema. We want to achieve a high working pressure. Again, when the patient's muscles are pumping, we want it to feel the resistance against the bandages, and a low resting pressure. So when the patient's at rest, the bandages are still doing their job. It's still about a 20 to 30 millimeter of mercury pressure at rest, But when the patient is up and walking, the pressures are much higher. And this helps to pump the blood, the excess edema in the interstitium back into the lymphatics and pumps it up out of the limb. The long stretch bandaging, or ACE bandages, can be used for an acute edema, sports injuries, and if this has a low working pressure and a high resting pressure, I'm sure any of you who are athletes who have ever had a ACE bandage on, you feel a lot of pressure from this bandage. But since the bandage has a lot of stretch, when you're moving, the bandages stretches too. So you're not getting a high working pressure, you get a low working pressure. And then the pressure gradient should steadily decrease. You'll have a higher at the distal with short stretch bandages and lower as it goes proximal. And you use multiple layers to achieve the pressure that you need to get the containment and reduction of swelling. So some contraindications and precautions for bandaging, of course, is arterial disease. If there's any concern or question at all about a patient's arterial flow, or in some places, if you have access to a vascular surgeon, it would be recommended, if there's any concern about their arterial flow, to have an ABPI test, an ankle brachial pressure index test done, because this will determine what level of bandaging, compression, and what millimeters of mercury you can apply to the skin safely without creating a risk of ischemia with the compression bandaging. So again, checking the ABI can be usually tolerate the bandage if it's 0.8 or higher. If it's lower, the vascular clearance needs to be given. And if it's below 0.5, there should be no compression applied to the skin onto the limb at all. You want to be cautious with bandaging, immediate removal if the patient has pain, like significant pain or cyanosis. Certainly with the bandaging, the bandages, because it's a low resting pressure, the bandages should be comfortable when they're applied on the patient. And often patients whose skin has been stretched a lot by their lymphedema, when you first start applying the bandages, there's actually almost a sense of relief. They feel comfortable in the bandages because it feels like their skin is being contained. If the patient is in pain, it means that you've applied them too tight. You can get containment without pain. And so this is what we teach in the certification course, or if you take a bandaging and compression course with short stretch bandages, you will learn how to apply the bandages properly to get the most effective results for patients. Of course, if there's any neurological conditions, you want to use caution. If there's sensory loss, or if elevate the legs on the wheelchair. With diabetes, of course, with the neuropathy, you need to use the bandages with caution, that the patient is not being bandaged too tight. And with hypertension, use caution because of the return of additional fluid to the circulation. This may increase their blood pressure if poorly controlled. And so you want to check their blood pressure before and after CDT and applying bandaging, just to make sure the patient is tolerating it and they're not having anxiety and they're able to tolerate the bandages that you've applied. So skincare in the intensive phase. The goal is to protect the barrier function and to prevent cellulitis from occurring. Because anytime a patient gets any type of break in the skin, when they already have a lymphedema, those patients are at risk for increased infection of cellulitis. So if you have any patients that you've seen that have come in and out of hospital with cellulitis, and the edema gets a little bit bigger each time, but that edema is not being reduced 100%, you might have a patient that has a recurring cellulitis that is being diagnosed with edema that actually might now be a lymphedema. And so in order to get that edema from those cellulitis infections out of the limb, the complete decongestive therapy will be amazing and really help put them on a healthier path of having less repeat infections in the future. But then once the intensive phase is done, they need to be fitted for proper compression garments, which we're going to talk about still. And then the daily routine should be a patient, once they're in the daily intensive phase with the therapist is gently cleansing. We're thoroughly drying the skin, even between the toes or the fingers, wherever they're being treated, and moisturize to prevent cracks. Always a patient needs to be educated to monitor for infection. So what is cellulitis? What are the signs and symptoms? What is an infection? It's when there's an increase, when the skin feels warm, there's a spreading of redness, fever, sudden pain. definitely the patient should be sent to seek urgent evaluation by a doctor, a medical practitioner, to ensure if they need to be put on antibiotics. And again, address the risk points if there are potential fungal infections, cuts, blisters, insect bites. Prompt treatment and protection should be initiated. Also maintain clean, moisturized skin, as this therapist is doing here in the picture. And you want to prevent cuts and infection, treat any fungal or bacterial infections early, and avoid injections and blood pressure cuffs on the affected limb. So this is an important point in breast cancer patients. You know, often we, in their education, they're all taught to not inject or put a blood pressure cuff on a patient after breast cancer on that side. It's because they have had lymph nodes removed. And if you do pump up the blood pressure cuff that high, it could bring more blood flow to the area. And again, because they've had lymph nodes removed or radiation, they might not all drain out after you're done with that blood pressure taking. So rather always take it on the opposite side, and any injections or blood drawing should always be done on an opposite limb, not the breast cancer limb side. And then exercise in the intensive phase. The goal is to use the muscle pump to support lymph flow out of the limb while wearing compression when recommended. Preferred types is low impact aerobic, range of motion, light resistance with gradual progression. And then dosing, rather do short, frequent sessions of exercise. However, they should stop if the swelling or the pain increases, and to then reassess go back to the physiotherapist and figure out an adjusted way of doing the exercise. And then breathing. Diaphragmatic breathing is very important in lymphatic flow. And as we did do this demonstration last week, but for those of you who weren't on the call last week, so diaphragmatic breathing, you want to put your hands just below your rib cage, and you want to breathe in, teaching the patient to breathe in really deep, in through the nose, holding it for a few seconds, and then breathing out through the mouth. And this diaphragmatic breathing can assist with the central lymphatic fluid return and relaxation. And it really helps to drain the abdominal area, clearing the trunk. But again, this system of breathing should be repeated several times, not just done once. And then, of course, exercises. So the maintenance phase overview is to sustain the reduction. So now the intensive phase, you've seen the patient 5 days a week or 3 days a week for a few weeks. They've been doing the manual lymph drainage. They're wearing the compression bandages. They came in with this much swelling, and now you've reduced them to more manageable amounts. And the reduction you need to keep long-term now. And you want to prevent flare-ups through daily self-management, right? So the emphasis shifts from the frequent clinic visits to then patients being responsible for their home routines. But even with this, periodic assessment or reassessment is so valuable and so important. You want to catch and check on them after they've finished the intensive phase. You get them into a long-term compression garment, whether that's a circular neck garment, knee-high, thigh-high, pantyhose, whether it's an arm sleeve or glove, depending on what the problem is and what type of compression they need. You want them to come back after they started wearing this garment, at least a few days after you've given it to them. And then again, maybe a month later. Let's make sure that this compression garment that's been provided to maintain this reduction of edema is actually keeping the swelling under control, that the patient's wearing it, that they're happy, that they're comfortable. And they should always have two, one to wash and one to wear. You can't just dispense one garment. It's not enough. And in fact, some patients, depending on what level of lymphedema they came in with, a lot of patients need a daytime garment and a nighttime garment. And of course, the triggers to plan for, right? If a patient travels, when traveling, they should bring a daytime and a nighttime garment. Sometimes heat can make the swelling worse, illness, changes in activity, and you want to adjust the compression and care accordingly, and perhaps maybe a low level of compression, a compression class 1 or 2 is not enough. A patient needs a compression class 3 or even a compression class 4 millimeters of mercury compression garment, and not a lower stage. And the importance of understanding this and the importance of this aspect, the maintenance phase, I can't stress enough. It's the same as the prescription strength garment that you're giving to them long term. is just as important if a patient has a diagnosis of cancer. When that patient has a diagnosis of cancer, the doctor would never prescribe a Panado. They would prescribe the proper chemotherapy because that's the right prescription strength dose of what that patient needs to be healed and then to stay healed. And it's the same with compression garment material on the surface of the skin. You have to look at it as a prescription strength medication on the skin to keep swelling under control. And if you think of it in those terms, you understand the importance of how important it is to ensure that the patient is in the proper level of containment and compression, and not doing so or giving them just a TED hose or a DVT stocking. That's not a gradient compression garment. And a TED hose is not enough compression for someone that has a stage 2 or stage 3 lymphedema for maintenance. It might be okay for a very mild edema or a very early stage 1, but not for patients that really need more containment. So the daytime garments are measured and fitted once the limb is volume stabilized, and it provides consistent therapeutic compression on a daily basis. The nighttime options are either the patient will continue with the bandaging that you used in the intensive phase or they can get a quilted garment or bandage to prevent the overnight refill. And again, some patients do have a quick refill. Others are fine just wearing a daytime garment. But if they find that over time, they're having a harder time putting their daytime garment on in the morning because they weren't wearing compression at night, this is your trigger to know they need to be fitted or to do some type of compression at night as well. The fit matters. It's so important to also understand most of these compression, well, not most, every single compression garment company, I think in the world, the guarantee of these compression garments is only for 6 months. You get a 6-month prescription of each garment that you buy. So if you're only buying one, that needs to be replaced in 6 months. If you are buying two, potentially you might be okay. You got to check in on them in 6 months. If the garments are still maintaining the edema, then fine. But if the patient is starting to swell, they need another set of garments at that 6-month mark, and then they'll be good for another 6 months. So the garments need to be checked on. Of course, it depends on how rough the patient is with the garment, how they wash it, how they wear it, how active they are. And so this is all coming in depending on the wear. And then you want to check that the size is still appropriate, that they're not getting slippage, that the garment's not sliding down, because now they've reduced even more with wearing the compression garment you've issued. And you want to check for skin marks. Is the garment now too tight because they are getting some swelling? They're not bandaging at night and they need to do something for day and night. And then, of course, the most important thing and my passion is teaching patients, you can give them the most amazing, appropriate, effective garment for them. But if they cannot put that garment on and take it off themselves and or teach a family member or caregiver to do that for them properly, it's going to be a problem. So the donning and doffing aids are very valuable, and that is something definitely to learn about. And of course, washing the garment with with a mild detergent, with no fabric softeners, because fabric softeners will loosen the material and you won't get 6 months out of the garment. And rather hand wash in, a sunlight liquid or just a basic type of gentle cleanser. Either you can machine wash some of the garments, but ensure that it's in cold water and not too hot. And then also to upsize or downsize when there is a difference in the volume of the edema. So the different types of garments, there's circular knit and flat knit. Compression science is a whole nother course in itself, which I'm very passionate about. So there's, like I said, it's a prescription strength. So there's compression class 1, 2, 3, and 4. The measurement, you do measure at different intervals of the limb, whether it's the arm or the legs, and circumferential measurements. You want to have a proper sizing and a professional fitting with someone who knows what they're doing. And you use this in the maintenance phase. The compression garments are used. Circular knit garments are knitted without seams. So these are usually the type of garments you can buy off the shelf at medical supply stores. Flat knit compression garments are knitted on one flat piece, and then they're seamed together because they're made custom to the patient. However, there are ready-to-wear flat knit garments now, and they're much more comfortable, much more containing, and they're just a better, higher quality of compression for patients that have stage 2 or stage 3 edema. And RTW stands for ready to wear, and sometimes it's labeled as OTS, off the shelf. So usually these circular knit garments are these type, but again, you can get some flat knit garments in ready to wear. So frequently used as a prophylactic garment for patients at risk for lymphedema. So even patients who don't have swelling yet, especially breast cancer patients, there's been a lot of studies, and perhaps Janet, you'll be able to share, that information, but worldwide, there's studies to see if there's a benefit to wearing a prophylactic garment at a lower compression, especially when a patient flies in an airplane, because everybody gets a little bit more swelling in their limbs when they fly, and if someone that has had lymph nodes removed and at risk for developing swelling, it might be beneficial for them to wear a compression garment before flying and or starting a new exercise program. And so this would be a patient with mild to moderate lymphedema, patient who cannot afford the more expensive custom-made garments, and they are available quickly, circular knit, because they're off the shelf, but they're not as strong as flat knit or as containing. And ready to wear may slip into the soft tissue creases and create a tourniquet. And this can create the tourniquet effect, which isn't comfortable for the patient and could be detrimental and or cause more swelling in an adjacent area. So flat knit garments are ideal for patients with lymphedema, and it offers more containment than circular knit. It's usually custom made, and there's so many different color choices for flat knit garments, depending on the company you're ordering from. So there's a lot of different choices depending on the make. So compression class 1, what does that mean? So depending on the country, so when I practiced in America, when I first started, compression class 1 in the USA is 15 to 20 millimeters of mercury pressure. But German standards are 14 to 18 for upper extremity and 18 to 21 in lower extremity. This compression class 1 really is just for mild lymphedema, or if you want to do prevention of lymphedema in an arm after breast cancer. Or some therapists feel like compression class 1, if the patient's having a hard time applying the garment, you can layer garments. You can layer 2 compression class 1 garments, one over the other. And of course, in pediatric little kiddies, lymphedema can be started at a compression class 1 and then used as a prophylaxis as well. Compression class 2 in upper extremity is 20 to 25 millimeters of mercury in upper extremity, and 23 to 32 for lower extremity. And again, these are Germany, and perhaps France uses these different millimeters of mercury. In the US, it would be classified as 20 to 30. They keep it simple for us Americans. It is recommended for moderate lymphedema of the upper extremity, mild lymphedema of the lower extremity, and moderate to severe pediatric children with lymphedema, and then just basic lymphedema. And then compression class 3, in my clinic in Miami, Florida, our go-to after the decongested phase was we would start patients at a baseline of compression class 3. That would be enough containment to ensure that the patient would have a good results long-term. The biggest problem with not putting a patient into the proper level of compression is this, that you're telling the patient the wear schedule, how long to wear the garment. If you don't put them into the correct compression class, and it's not containing them as much as it should be, they're doing everything you tell them to do, they're wearing the compression garment every day, and they're still swelling because it's not enough containment. So if the patient comes back after a week and says they're still swelling, that's a note to self to say this patient might need a compression class 3 and not a compression class 2. But that compression class 2 won't be to waste. They could, if they have good sensation in their feet or in their arm, a compression class 2 garment can be safely used at night. But again, you need to use your clinical reasoning and discretion before recommending this, and approval from the physician, the referring physician as well. And then there's compression class 3 Forte. And this is only available for lower extremity, and this is a little bit firmer. And then the stronger fabric for when the donning is not a problem, recommended for moderate lymphedema for lower extremity and severe lymphedema of the upper extremity when donning is not a problem. And then compression class 4. So this is between 49 to 70 millimeters of mercury. This is a lot of containment. And this is for those patients that have been, in that stage 3 elephantiasis stage, and you've decongested them with the MLD and the bandaging. That patient's skin wants to swell up again. So really, in order to contain that reduction that you achieve in those big elephantiasis patients, it's really the best choice as long as the patient's able to tolerate a compression class 4. This is an amazing product. It provides the containment that they need. And this is when a patient may need more than a class 3 forte, and when they are agile enough and strong enough to be able to apply a compression class 4. But with the donning devices, it is possible. And then a class 4 super is for lower extremity only. And this can go from up to 60 to 90 millimeters of mercury in certain brands of compression companies that manufacture this. Let me just say, yeah. So self-MLD. So this now that they're in the maintenance phase, again, the purpose of self-manual lymph drainage is they need to continue to maintain this flow between visits to the therapist. And again, it's not just, doing it for, yes?
Hi, once again, Susie.
Can you see?
Yeah, thank you. We can see your presentation. It's been good. Only that we are pressed for time.
Okay, so let me go through the rest of the slides a little bit quicker. Sorry. How many? Okay. So the self-care
actually,
exercise.
You don't need to rush through it. I was suggesting maybe we can do a part 2 of this maintenance phase on next week's talk on Thursday, so we can have you so that we can complete it all.
Okay, that sounds like a great idea.
Yeah.
Because there's still,
so we can stop. Yeah.
Okay, then we can ask any questions that people have. I'll stop sharing.
So we can. Yes. Thank you. Yeah, Dr. Mustafa, I think we can proceed with the Q&A now.
Okay, great. Thank you very much, both presenters. We have a couple of questions in the Q&A. The first question is from a lady who's asked, is MLD contraindicated in patient with IUD? IUD, I mean, you mean intrauterine devices? So this question open to both the presenters, Janet and Susie, if you can take this up.
I've never heard of an IUD being a contraindication for treatment, but if the IUD placement is a problem causing the swelling, then that would be something that would need to be diagnosed properly by the doctor who inserted the IUD and to get clearance to do manual lymph drainage. First, find out what why the patient is swelling, if it's caused by the IUD. But otherwise, Janet, do you agree, like just having an IUD should not be a contraindication for doing manual lymph drainage, because the diaphragmatic breathing shouldn't be compromised?
Exactly, I think I confirm that. I don't think indication to lymphatic drainage by any intrauterine contraceptive devices.
I see a question is, which instrument is used to measure the quality of compression? So there's different types of compression sensors that measures the level of compression. But this is where, whatever a good quality compression garment you purchase, knowing on the outside of the box, it can say compression class 1, 2, or 3, but you need to know the numbers. Depending on what country the garment is manufactured in will determine what level of compression that patient is actually getting. And again, remember, the guarantee is only for 6 months. So after 6 months, they're probably not getting that level of compression anymore.
Yeah, and I think if I may just add to that, and often patients come to me complaining that, oh, the garment is too tight, I'm not fitting it really well, and then they're really, really non-compliant. So I over and over again, and I asked them, how did you get the stocking? I said, oh, I just went to the pharmacist, and they said, oh, you're a large, and they gave me a large pair, or they gave me a medium pair, but they never really measured the appropriate size. They were never fitted properly for those stockings. So what I advise patients is make sure you visit your lymphedema physiotherapist and that they measure what size you require. And I always insist on that. And I usually insist on sizes just above the ankle, below the knee, above the knee, and upper thigh. So then you can appropriately be fitted for what compression garment you need. Anything else you want
Janice?
to do you want to say anything?
We ask Dr. Mustafa.
No, you want to add anything in terms of being properly fitted for a stocking, not just to buy them off the shelf.
So the compression stocking is what we are talking about here. I think I'm losing you, Dr.
Yes.
Mustafa. Oh, okay,
Yes,
yeah.
yes.
Yeah. I think they need to be prescribed well. They just don't go over the shelf and buy I want this compression, because we need the measurements again. We need the measurement, the precise measurements in this matter, not just any measurement, so that you get the right wear for you, which is actually going to assist you with the condition.
Right. The other thing I will add, again, if you're not sure, the ABPI, checking their arterial flow, will dictate what level of compression is safe to put on that patient's skin, right? You don't want to put a compression class 4 if the patient has a ABI of 0.8, right? Then they should only be in like a compression class 1 to compression class 2 safely. So it's really important that, but the measuring is the most important. And if the patient is really uncomfortable, it's not the right product for that patient, because really there are so many different manufacturers of different levels of compression, different materials, different textiles. Maybe they need a flat knit instead of a circular knit. They will have a completely different experience. The same, again, you have a different experience. If you have an infection, a cellulitis, again, going back to that example, you don't give them a baby aspirin if they need an antibiotic. It's not going to work. And that's why the compression garment's not working. They're not being fitted with the right material for their particular issue. So they need to go and talk to their lymphedema therapist, and hopefully she or he has a lot more options of different brands that they can share with that patient.
Yeah, and I think I'll just add on to the ABPI point, and this is really, really important, because in these patients, lymphedema patients and patients who have massive swelling of the leg, at times it's really, really difficult to feel for their distal pulses. So many times you put your fingers on and you can't feel the pulse really well, and you can't feel the posterior tibial or the dorsalis pedis pulse. Always send them for an ABPI or even just an arterial doctor, which will ensure that there is good perfusion, the arterial supply is not affected. Because we've had some patients who've come when they have both arterial and venous plus lymphatic related limb swellings, and they've been wearing prescribed a stocking, and the fingertips are just getting dusky and blue. So it's really, really important to ensure that the peripheral perfusion is.
Absolutely. It's so important. I think, I'll have to admit that in my initial lymphedema training in 1998, I didn't learn about ABPI and how important it is before applying compression. So when I did learn about it a few years later, very abruptly from a doctor who was questioning me, asking me, what's the ABI on this patient? And I didn't have that answer. It was a real wake-up call for me to understand and know, it is such a super important thing to understand. And as clinicians, we should be referring to the vascular doctors to have this test done, or several wound care sisters here in South Africa. They actually do it within their clinics. Sometimes the vascular surgeons have a very long wait to get an ABPI done. So it's very important to understand and know, and then you can understand safely apply the proper level of compression. I see there's another question that says, is this going to be lifelong? And what is the success rate of MLD? Is there any effect of high compression? Yeah. Sorry. Janet, do you want to?
Yeah, it's so if is this going to be lifelong? what is the success rate of MLD, and is there any effect of the high compression pressure on tissue perfusion? So I think earlier, Susie, you talked about the MLD, when it works and all that. Yeah, so if it's going to be a lifelong, if lymphedema is going to be a lifelong condition, yes, especially if it gets you at stage 2 and up to stage 3, it is actually disabling. Live along, lifelong, it can be a disabling condition. I think there's a leg you actually saw earlier when I was sharing about the staging. So what is the success rate of the MLD? Now, the success rate of MLD is very high. Basically, if you do it in the right way. Sometimes you're going to be doing MLD. MLD, is not something that you're going to be doing in a rush. Proper manual lymphatic drainage takes at least 45 to 60 minutes. Proper one, whether it is the therapist who is doing or whether it is the patient or the caregiver who is doing, it has to take at least 45 to 60 minutes, and you need to follow it as it is supposed to be. You need to drain proximal first, and then distal, and then now the target area. And it is, you actually, by the time you're already finishing your MLD, you should be already be seeing changes in the reduction of the swelling and all that. But now remember, in this aspect, we are not going to be doing the MLD alone. The definite treatment for, lymphedema here is the combined decongestive therapy. So you do MLD and you let that patient go home without compression, that foot or that limb is going to swell again. So it is only right, it's going to be successful if you do it in the right way, and it is very successful for patients that I have seen personally. By the time we are finishing the MLD session, they want to go pee, the limbs, there's a lot of limb reduction even before we start our taping and even before we start our bandaging, and now you're going to get results. Remember, if you keep on bandaging your patient, skipping the MLD bit, you're also not going to get results that you expect. So is there any effect of the high compression pressure on tissue perfusion? Our bandages, Susie, you explained that earlier about the short stretch bandages and the pressure and the Starling's law. So there is all that consideration, and that is why those bandages need to be applied by someone who has been taught, even if it is not a certified lymphedema therapist. I have done trainings locally and also out of the country, and we focus, when we do our workshop, we want to make sure that we have a practical session so that people can understand, at least even if you do not have like the whole information of this and this and this, when you're going back to refer into your books and also making maybe consultations, then we guide you well. But at least you need a practical session, because you're not going just to be putting a lot of pressure. We are so many times we are into stability, especially as physiotherapists now, because we are the ones who do this bit. When we are stabilizing the extremities and all that, we put more pressure. Even when we are taping, we put more pressure for stability. Now we have to get the difference between when we are doing stability and lymphedema here. Lymphedema is actually, again, an integumentary condition, a skin. I said that last in our previous presentation. So our target here is not even in the tissue, as much as we are targeting muscle action and range of motion and all that. Remember, it's all in the skin. So we have to be gentle, we have to be rhythmic, and we have to be as soft as we can. So as you put the pressure, the bandages are graded from a smaller bandage to a bigger bandage. And the bigger the bandage it is, the less the pressure. So a smaller bandage, it's like the pressure is going to be graduated. So we're not going to get any perfusion on the tissues and all that. Maybe my teacher, Susie, can add, if anything.
No, I think you've answered it beautifully, Janet. And I think, that it's just going to help keep everything contained, and the concern, again, it needs to be applied properly. I think that's the most important thing, and having that low resting pressure and high working pressure.
I think there's some other questions in the chat box, and I'm not sure how much more time we have left, but one of the anonymous attendee who is asking, is it safe to say there's no 100% recovery from lymphedema? especially for stages 2 and 3, only long-term management to prevent recurring. What do you have to say, Susie, Janet?
Should I go, Susie? Yeah, it's okay. So is it safe again to say there is no 100% recovery from lymphedema, especially for stage 2 and stage 3? Only long-term management to prevent recurring. 100%, I say yes. As
I
you know,
say
it's
yes.
as simple as you've just said it. This is this anonymous attendee is a bright student. I say yes, because again, earlier I also said something about it being disabling. And when I was doing my presentation on the staging, I said that stage 2 is spontaneously irreversible. I don't want to actually classify stage 2 further to class 2A and class 2B, where class 2A is when you actually get it and you can actually get good results. But honestly, for that big limp which I show there, we will do all these treatments. We can help this patient live a good life and, more mobility and get back to work, reduce the stigma with management and all that. But we are probably not going to get that other leg 100% the level of the normal leg. Yes. So anonymous attendee, yes. There is no 100% recovery for stage 2 and stage 3. Probably with more science, Susie, we can come up with something.
Yes.
To do that.
AI.
Yes.
In the future, it will be different, but right now there's really no cure. So the best that we can do is to really educate the patient and the family how important the compression is, like the compression science behind the patients have to be educated that it's just as important as taking their pill every morning. They need to wear their compression garment. And that's where it's us as healthcare practitioners to find a product that's going to be the right product for their skin. Just as a doctor doesn't give up on one antibiotic, you try a second one or a third one until you get that infection under control. It's the same as you've got to find the right compression material that will keep that patient's swelling under control. So super important. Yeah.
So there's this one here. Okay, like, have you supported home-based lymphedema management for patients as a result of lymphatic filariasis? What did you say? Have you supported home-based lymphedema management for patients as a result of lymphatic filariasis? Any key highlights to teach patients on self-care? Oh yeah, that's personal. Okay, I would say patients with lymphedema as a result of the lymphatic filariasis, yes, we've been able to manage them. However, there is a very big gap, and I think that is why one thing we are doing all these webinar series to create awareness, to enhance, advocate for early detection and more education. We have a real big gap here in Kenya because we only have 14 lymphedema therapists. That is what Susie said earlier. Trained from Lymph Africa Education, an institution in South Africa. So having that wouldn't really cover so many patients for home-based care, and because we are actually even also situated in major hospitals within Nairobi City, and that is where we are targeting so that we can have these extended to the county hospital and even to the local facilities where we are. Lymphedema has to be picked up, but about if I have actually supported, I would, if we really had the manpower. But at the moment, I would only encourage the patients to come to the facility, because if I leave the facility and I come to your home to attend to you, then I think I'm really going to leave a lot of patients in the facility. Susie, I don't know how you do it back in South Africa, but I think I've also had some contacts from South Africa and I had to send them your way, calling home care, yes.
It's very challenging. It's very, we do the best that we can. And that's where the outreach and more lymphedema awareness that patients don't slip through the cracks. And if they can get to a tertiary hospital to get more intensive care, they can be admitted to the hospital. And then we have certified lymphedema therapists in the main tertiary hospital, government hospitals here in South Africa. we were giving 50% discount for any therapist within the government system that would want to come to the certification course. So there are several therapists within the government sector, we're very proud to say, in the physio and occupational therapy departments, and even getting into the proper compression garments, they've gotten that on tender. So here in Cape Town, we really are very progressive. I'm very proud of the shifts that we made in awareness. But there's still a lot more to go in the private and government systems. So it's very challenging when patients are in the far, far outlying areas. And so if we can inspire those therapists to come for training or to do more online training, we'll teach you how to do it properly and do the best that you can, because something is better than nothing, but doing it properly, that's something that you're doing is really important. So you're not causing more problems for the patient. Thank you.
Okay, yeah, thank you, Susie. So Dr. Mustafa left, he's going for surgery.
Okay.
So I think we're going to be closing with Nelson today, and we've actually hit 1,100 and plus today. So next time, let's roll these banners out. We want 2,000. So I have seen people from Busia.
Kampala,
the doctor.
Pascal.
Oh, yeah. So yeah, we've seen the people from Kampala, from Busia, from Kakamega, from Mombasa, from Malindi, all over, you know, we are all over.
Amazing.
Even Meru. So the next time, let us have people from all parts of this world. And I would like to mention that we are going to be celebrating the first ever World Lymphedema Day in Kenya, here at Kenyatta National Hospital on the 6th of March, 2026. We are going to be having free screening for our patients on the 4th and 5th. That will be a Wednesday and a Thursday. And also the same day of the event, which is going to be on a Friday. And we would like to welcome all of you to come, send patients. If you've seen anyone with this condition, let them come for the screening. Let them come and let's celebrate this day together. It is not only a celebration. This is unlocking history. This day we are basically creating awareness. We are recognizing these patients who are termed as victims of lymphedema, because most of the time they face a lot of stigma, and we are advocating so that we are going to have healthcare policies even formulated for this condition, and also more people trained in management of lymphedema. So I'm going to toss to Susie, say something, and then back to Nelson.
Thank you so much, Janet. So I just want to say thank you so much to everyone who's been on this call today. Like, overwhelmed and so grateful and honored and proud, Janet, that you've put this together, and we've had over 1,100 participants. It's just mind-blowing. And I do hope that we've inspired you to want to learn a little bit more and to make a difference in patients' lives, because that's what it's all about. We do this work and teach these courses and create these online modules. We are rolling out a whole series of additional virtual and online courses, Janet. So hopefully I'll be able to come back to Nairobi for a refresher course, or to support you in your efforts to roll out a certified lymphedema course there. And we're here to support you all along the way. And again, just teaching about compression science and the importance of how people need to understand and respect that it really needs to be done properly. So thank you for all of your effort, and thank you for everyone who's been on this call today. It's lymphmedical.com now. It used to be Lymph Africa Education, and we still are, but we're rolling out more international courses. So we've evolved our business model to be Lymph Medical Academy and Lymph Medical. So you can find us on lymphmedical.com if you're interested in taking one of our online courses, or come to South Africa. Come see us in Cape Town. It's amazing here. You will regret it. Thank you.
All right. I would like to thank the presenters so much for organizing this series. It has been enlightening. We will be having a part 2 of the maintenance continuation next week on Thursday. So stay tuned for that. We'll send you notifications through your email addresses. And we will also be back on Monday on the platform with the nutrition series. We'll be looking at nutrition in treating diabetes. So kindly look out for that on your reminder emails. My name is Nelson for KNH Research. Would also like to thank the participants for joining us. Your support has been overwhelming in this series, and please invite other colleagues, invite patients that you feel will benefit from this type of platform, especially for the sixth that's coming up, the World Lymphoedema Day. I'd like to thank you once again all for joining. See you and have a wonderful afternoon.